Hello everyone, welcome to MBBS classes. Myself Dr. Hanifa. Today in this video I'll be talking on vocal nodule. To begin with, the vocal nodule it is one of the benign laryngeal lesions and it is a commonly diagnosed cause of the dysphonia. The other benign laryngeal lesions similar to the vocal nodule are the vocal cyst and the vocal polyp. In this video I'll be talking only on the vocal nodule. These vocal nodule, vocal cyst and vocal polyps, they are the phono-traumatic lesions of the vocal cord. The reason is the vocal cords are subjected to the mechanical stress during the phonation. The type of stress is mainly the impact which occurs during the collision of the vibratory surfaces of the vocal cord, and it is seen in people with the habit of vocal overuse, which may be in the form of excessive use of voice, abuse of voice, or misuse of voice. So you can see here, this is a laryngoscopic image showing the vocal cords, and you can see here bilateral whitish colored nodules over the vocal cord. If you see the location for describing the type and for describing the location, we divide the vocal cords into three equal parts. So this will be the anterior one third, this will be the middle third, and this will be the posterior third. So you can see here these bilateral vocal nodules are present at the junction of anterior and the middle third of the vocal cords. And this location, it is the commonest site for the occurrence of vocal nodule. The reason is that this site is subjected to the maximal impact during the phonation. Now let's see the pathology of and the differences between these three phono-traumatic lesions. So if we see here the vocal nodule, they are the calluses on the vocal folds. Second is the vocal polyp. These vocal polyps, these are the epithelial lined outpouching and which contains either a mucoid type or a fibrous type of substances. They may have a pedicle, then it is called pedunculated, and when it is not without any pedicle, they may be sessile type. And the vocal cyst, it is mainly an epithelial lined mass. The vocal nodule is also known by the other names. It is also called as singer's nodule, teacher's nodule, or screamer's nodule, as it is commonly found in the people belonging to these professions, and these group of professionals, they are most commonly subjected to the overuse of voice. So if you see the etiology of the vocal nodule, so we know that it occurs as a result of overuse or abuse of the voice. It can be yelling or vocal hyperfunction, which results in the impact stress during the collision of the vibratory surface of the vocal cords. And this trauma, which results in the vocal nodule, it will not be in one attempt. Due to the repetitive traumas, it results in the wound formation within the superficial layer of the lamina propria and sometimes may involve the vocal fold epithelium also. So, the certain group of professions like singers, teachers, and hawkers, when they have to use their voice regularly, they suffer from repetitive trauma. There are certain predisposing conditions which can precipitate the nodules sign and symptoms. It can be gastroesophageal reflux and sometimes due to the velopharyngeal insufficiency. So if we see the characteristic, it can affect both the children and the adults. And if we see the gender differentiation, it is seen that among children, the boys are affected more than the girls. An occupation, we know it is the most commonly it is seen in teachers and the singers. So when we are taking a history of a case of dysphonia or the voice change, you must take into account the occupation of the patient and the nature of the use of the voice. Now let's see the characteristic of the vocal nodule. The vocal nodules, when we have to differentiate between the phonotraumatic lesions, which could be vocal nodule, cyst, or the polyp. So how a vocal nodule looks like. First of all, remember the most of the vocal nodules, they are symmetric and they are bilateral. The most common site is, we have seen that it arises at the junction of anterior and the middle third of the vocal cord on the free margin. This is the free margin of the vocal cord, because this area is the site of maximal stress during the phonation, or during the when these vocal cords they vibrate. How does it look like? It appears like whitish, or it may be sometimes grayish in color, and it has a opaque and a firm texture. The size may vary from pinhead to half a size of a pea or a seed. So whenever we are documenting the laryngoscopic features of any lesions over the vocal cord, we must record the look of the lesion, we must record the site, we must record whether it is bilateral, and any other associated changes over the laryngeal mucosa. Now let's see the stages of the vocal nodule formation. So there are three stages of formation. The first stage, which occurs after a trauma during the phonation, is this. It results in inflammation. So due to the inflammation, there is an increased vascularity and the accumulation of protein. Then in the second stage, when these localized swellings which appears on the edge of the vocal cord, at this stage they become grayish and they become translucent. There will be a look will be of a thickening. And this stage is very important, because if a patient is coming in the stage 2, and this is a reversible stage, and the reason is, if the further trauma to the voice box or the larynx is avoided, then it can revert back to normal. But if a patient is not coming to you in the stage 2, or when the patient has a history of repetitive trauma, then what happens? There is a replacement of these translucent thickening by the fibrotic tissue, and then it becomes gray or white in color. So ultimately the vocal nodule, it assumes a look of a callus formation over the vocal cords. So as we know that the vocal nodules, it is a very much common cause of dysphonia or the voice disorders. So dysphonia is a abnormal voice quality. So the patient may present to you with hoarseness of voice, breaks in the voice. They will give a history of vocal fatigue. That means after talking for some time, the patient will tell that I'm not able to raise my voice. And moreover, they may also complain of the pain in the neck on the prolonged use of voice. So how to diagnose? So these phono-traumatic lesions, they are best diagnosed on the history and the physical examination. So the differentiation can be made on the video stroboscopy. They are also differentiated on the characteristic appearance of the individual lesions. So we have seen that the vocal nodules, they are whitish to grayish, firm lesions, they are bilateral and they are symmetrical. The polyps, if we see, they are unilateral and they appear from translucent to reddish in color, which may be sessile or pedunculated. And again, the vocal cysts, they are not very much common lesions. They appear as a yellow masses. So when we are doing the laryngoscopic examination, the differentiation can be made during that time only. Then we have to see the extent of disruption of the vocal cord vibration. What happens in case of vocal nodule? It results in hourglass closure glottal configuration, and it affects the vocal fold mucosal wave and vibration. Again, it depends on the size of the nodule and the associated edema. A vocal polyp, generally it doesn't affect the mucosal wave, and in case of cyst, again the mucosal wave may be affected if it is too big in size. Another diagnostic test which is of helpful in these phonotraumatic lesion is the optical coherence tomography, or it is also called as OCT. The advantage of OCT is that it is non-invasive, non-contact technology for diagnosis of the phonotraumatic lesions. The advantage is that it allows detailed imaging of the vocal fold by using the cross-sectional images which are obtained by the reflected light. So coming to the treatment of these phonotraumatic lesions, and in case of the vocal nodule, there are two type of treatment which is given to the patient. The first is the conservative. Under conservative falls the behavioral intervention and the voice therapy. And this is the initial treatment which is given to the patients. And next is the surgical intervention. The behavioral intervention and the voice therapy is the first line of treatment for the phonotraumatic lesions. Here, the patients are educated and they are taught to use the voice properly. The goal of the voice therapy is, remember, to maximize the efficiency of phonation, to eliminate the maladaptive behaviors which exaggerates these lesions, and it is seen that out of these phonotraumatic lesions, the vocal nodules are most responsive to the voice therapy. And this voice therapy, it is also helpful and it is recommended in the post-operative period to prevent the recurrences. Now let's see what are the principles of the surgical intervention. Surgery is not advised in the first stage of the management. It is recommended when the maximal behavior intervention and the voice therapy does not achieve satisfactory improvement in voice. So before you plan the patient for surgery, we must take into account the vocally demanding lifestyles and the occupation of the patient, because there may be some persons, not they may not be teachers, they may not be singers, and in them some change in voice is acceptable, and in those cases, you may not tell them or warrant them to undergo surgery. So it depends on the demand of the voice in their life. The other factors which are considered for the surgery is that the type and location of the lesions and the amount of functional impairment post surgery. And the probability of the surgical success, it depends on the type and the location of the lesions. For let us take an example like a large pedunculated polyp will give a good success rate. But on the other way around, the vocal fold cysts are very technically demanding, and in cases of vocal nodules, especially, the surgery is reserved for selected patients who do not respond to voice therapy and when the patient is willing to accept the risk of vocal fold scarring. So, in vocal nodule, the surgery is needed for the larger nodules which are not responsive to the behavioral therapy and the voice therapy. The treatment options for the surgery, it can be done by the microsurgical excision where operating microscope is used, and the other way of doing the excision is also by the CO2 laser. Post-operative period, the patient is advised to follow the voice rest for approximately 2 weeks, and the voice therapy is given in the post-operative period after the gap of 2 weeks to prevent the recurrence of these lesions. With this, I come to an end of this video. Thank you for watching this video.